Good evening and welcome you all. Today is the 143rd webinar since we started. And today's webinar is a real special webinar. Please go ahead, Anoop.
Yeah.
Thank you, sir. Thank you, ICA, for giving us this opportunity. So today, along with me, we have Dr. Anusha Cherian. She's a professor in Department of Critical Care from JIPMER, and they are having a DM Critical Care course there. So today's session will be something like a mock exam, where one of the DNB Critical Care trainees will be presenting a case. So usually in the DNB critical care practical exams, we'll be having two long cases where the candidates will be allowed to take a case for 30 minutes. After that, there will be a 30 minutes discussion. That will be done by two examiners together. So that is what we are going to mimic today. So along with me, we have Dr. Anusha, I've already told, and it is lucky that a few months before we were conducting exam together in Calicut. So I think it will be easy to do this session together. Over to Dr. Anusha.
Good evening, everyone. Thank you, ICA, for inviting me for this session today. So we will be starting this session without further delay with Dr. Dinesh. Over to Dr. Dinesh.
Yeah, Dinesh, before starting that 1 minute, so this will be like you have already seen the exam, no? So this will be just like the exam, where now you have examined the case for last 30 minutes, and now you are presenting the case. So the examiners will be interrupting you in between and will be asking you the questions. So after 30 minutes session, we will be having a debriefing sessions where both the examiners will tell you where or don't you did some mistakes, or where you could have done better, or which things you should have been avoided while discussion. Okay, so this is a very friendly discussion. So be very cool during the presentation. Whatever things you can answer, you answer that.
Yes, sir.
Yeah, proceed.
Good evening, respected teachers, faculties, and delegates who have joined. I am Dr. Dinesh. I am in my second year critical care residency in Baby Memorial Hospital, Calicut, Kerala. Today, I will be discussing a case, clinical scenario. Mrs. X, 38-year-old female, gravida 4, para 3, live 3, hailing from Kannur. She presented at 24 weeks of gestation. Her last menstrual period was on 18th July 2022. So she got admitted on 31st December 2021, and I will be describing my examination conducted on the same day, 31st 12 2022. So chief complaints, a 38-year-old female, gravida for P3L3. She presented with a fever for two days, a reduced fetal movement for 2 days, and breathlessness for 1 day. Before going into the before coming to our hospital, patient was initially admitted in a local hospital with the above mentioned complaints. In that hospital, she was found to have high blood pressure and was evaluated to have abnormally low blood counts, for which even one blood product had to be transfused. And in that hospital, an ultrasound was done, and intrauterine fetal demise was established. And for further workup and further management, the patient was shifted to our hospital because of the persisting fever and breathing difficulty. On arrival, now the history of presenting complaints, this patient developed a fever 2 days back, which was high grade, continuous, associated with chills and rigors, temporarily subsiding with antipyretics, but there was no history of breathlessness at the time of presentation. Patient also noticed reduced fetal movements over the past 1 day, but there was no history of leaking or bleeding PV or abdominal pain. Patient later developed shortness of breath, which was sudden in onset, gradually progressive. She has to catch breath while speaking, even she is not able to complete even one sentence. She had breathlessness at rest. But there was no history of cough with expectoration, chest pain, hemoptysis, headache, or abdominal pain. So to go about her present obstetric history, first trimester, she conceived spontaneously. After missing her first period, she did a urinary pregnancy test, which turned out to be positive. This was confirmed by the dating scan. She took folic acids in her first trimester. Prenatal checkup for blood pressures, blood sugars were all normal. She didn't have signs of anemia like breathing difficulty, pica, or fatigability. She didn't have any bleeding per vaginum or dysuria. During her second trimester, she felt quickening at 4 months and continued to perceive her fetal movements till 2 days back. Anomaly scan done at 20 weeks was reported to be normal. But at 22 weeks of gestation, that is 2 weeks prior to the presentation, patient had developed multiple abscesses involving thigh and axilla, which gradually progressed, which had to be incised and drained, and she had to get an antibiotic course for 5 days. And also during that admission, patient was also found to have high blood pressures, and she was initiated on antihypertensives after performing a urine test and rechecking her blood pressure next day. And she was currently on oral nifedipine 10 mg twice daily. But there was no history of headache, blurred vision, abdominal pain, bleeding per vaginum, swelling of legs, decreased urinary output, seizures, or any bleeding manifestations.
Yeah, Dinesh, 1 minute.
Yes, sir.
What is the significance of these history?
Since the patient is now found to have blood pressure, the blood pressure occurring after 20 weeks of pregnancy, we term it as gestational hypertension, and if it is with proteinuria, it could be preeclampsia, just from the history. So preeclampsia patients can move on to develop severe features. These are the, I had to rule out whether the patient had severe features like headache, blurred vision, implying cerebral edema, abdominal pain, implying liver sinus, liver capsule rupture, bleeding per vaginum, developing a coagulopathy in a preeclamptic patient, and swelling of legs, spiral edema, and decreased urinary output.
Fine,
Yes,
fine. Carry on.
Yes, sir. Menstrual history. So patient attained menarche at 13 years. The flow was for 3 to 4 days, relatively regular. Our LMP was July 2022.
It's
and
okay,
EC
you
was,
skip all those things,
yes, sir.
come to the relevant point.
Yes, sir. Past medical history was not significant. She didn't have any history of bleeding disorder, clotting disorder, no history of blood transfusion in the past, except for the one that was transfused the day before. Family history was insignificant, and there was no history of cough, breathing difficulty, fever in the close family members at the time of presentation. Personal history was normal. A vaccination, patient took TT vaccine in her second trimester, and she was vaccinated for COVID. To summarize my history, I have a 38-year-old female, gravida 4, para 3, live 3 at 24 weeks gestation with new recent onset hypertensive disorder of pregnancy diagnosed, on treatment with antihypertensives, and a recent past history of skin abscesses requiring IND. Now she has presented with a sudden onset fever, breathing difficulty, and reduced perception of fetal movements. And in an outside hospital, she was found to have low blood counts, and she was transfused 1 unit blood product.
Okay.
So yes, sir.
Okay. With this history, what will be your clinical diagnosis?
Clinical diagnosis right now will be my thought process will go towards preeclampsia, sir. Preeclampsia can have with preeclampsia with pulmonary edema. The patient has fever, breathing difficulty, and fever
will present with fever, breathing difficulty, and all.
Yes, sir. Another
patient I'm asking in particular, a patient at 4 weeks of gestation.
This patient had skin and soft tissue infection just prior to presentation, just 2 weeks back. Now she has presented with fever and breathing difficulty. So this could be a sepsis that is continuing, which is not
very good. So don't stick on to the hypertensive part alone. So there is a possibility of sepsis also.
Yes.
Yeah, go ahead.
Okay. On general examination, the patient was moderately built and nourished. She was dyspneic at rest. Height was 160 centimeter, body weight 65 kg, BMI was 24.4. She was conscious oriented but febrile to touch. Pallor was present, bilateral pleural edema was present, even upper edema with ecchymotic patches were seen. There was no ectocyanosis, clubbing, lymphadenopathy, thyroid swelling, or varicose veins. The vital signs: pulse rate was 124 per minute, regular, normal volume. All peripheral pulses were felt. Blood pressure was 180 over 110 millimeter mercury in right arm, left lateral position. Respiratory rate 24 per minute. Use of accessory muscles of respiration was noted. Her saturation was 90% in room air. It improved to 96% with oxygen via face mask at 4 liters per minute. Her temperature recorded was 100.8 degree Fahrenheit. So I did a focus examination. Cardiac wise, there was the LV function was normal, IVC was collapsing, but there was bilateral homogeneous B lines and no pericardial effusion per se. Lung sliding was present, no effusions, no air bronchograms. Abdominal, there was no free fluid collection in abdominal cavity. Compression ultrasound, bilateral femoral and popliteal veins were compressible. And I also did the optic nerve sheath diameter, and it was less than 5 mm, 50 mm. That was also within.
Just 1 minute. Why you did a optic diameter in this patient? What made you to do?
She's a from my preliminary findings, I had a preeclampsia patient with severe features, 180 over 110 millimeter mercury. So this patient, I have to ideally
just 1 minute. Hold on. So patient with a high BP, fully conscious, obeying with breathing difficulty. Do you expect that the patient will be having cerebral edema?
No, sir. Patient will have manifestations. Will have to develop symptoms.
So when will you suspect that the patient can have cerebral edema?
When the patient complains of headache, blurring of vision, I will definitely suspect
altered sensorium, recurrent seizures. That is the only point where you have to suspect. Like if you are not suspecting that there is like a completely fully conscious obeying patient without any focal neurological deficit, there is no point in looking for like optic sheath diameter and saying that there is no brain edema. Okay, yeah.
So this respiratory system, are you coming back to explain about it, or
yes, ma'am. Yes,
you're doing further?
Yes,
okay.
So clinical respiratory system examination.
We have only 30 minutes, Dinesh. So
yes,
you conclude your points rather than going with all negative findings. What are the positive findings you got? Just concentrate on that.
Yes, sir. Respiratory system alone, I like just brief, sir. Upper airways normal, trachea central, chest expansion was bilateral.
No, that's okay. We just want the positive findings.
Coarse crepitations were heard in over the dependent areas. CVS examination was normal. Apex was felt at the left. It was moved leftward and upward. So CNS examination within normal limits. Abdomen, there was no organomegaly. Obstetric examination, it was normal. There was on auscultation, fetal heart sound was not heard. So now to summarize my history and physical examination.
No, one more thing at that point. You have even looked at optic sheath diameter at that point. What else you should have done with an ultrasound at that point?
Sir, EFAST, abdomen examination.
What in the abdomen specifically?
Free fluid.
Other than that, simple thing. This patient already had an like ultrasound reports from outside. What was the report?
Absent fetal heart rate, fetal heart activity.
You should have just cross-checked and seen whether there is a fetal cardiac activity, no?
Yes, sir.
Okay, go ahead.
Yes. So to summarize my history and physical examination, a 38-year-old gravida for para 3 live free at 24 weeks of gestation with hypertensive disorder of pregnancy. Since 22 weeks on tab nifedipine, presented with fever, breathing difficulty, and reduced perception of fetal movements. Now, on examination, she has fever, pallor, extremity edemas, extremities edema, high blood pressure, signs of pulmonary edema and respiratory distress with hypoxemia, and absent fetal heart activity. So my provisional diagnosis at this point, 38-year-old female, now a possible severe preeclampsia and pulmonary edema. With anemia and intrauterine fetal death. My differential diagnosis at this point, since the patient had fever with breathing difficulty, I had to keep in mind sepsis, sepsis-related community-acquired pneumonia, and the patient had a intrauterine fetal death. A recent patient did not perceive movement for the past 2 days, but still, usually DIC occurs when the fetal products are retained for a longer time, but still. IUD related DIC proceeding to pulmonary edema features could be there, and pulmonary embolism and a distant amniotic fluid embolism was also in our mind. And hematologically, since the patient presented with very a spurious value of very low blood counts, as we had hematological issues.
Show the investigations first, then you go for all these sophisticated diagnosis.
Yes, sorry, sir. So the preliminary investigation I didn't. So this is the investigation when the patient arrived at our hospital. So hemoglobin of 6.7, total counts was elevated, platelet was 40,000, D-dimer was elevated, fibrinogen of 77, INR was 1.24, APDT elevated, urine routine showed albuminuria and hematuria. Right now, at the time of presentation, renal function test and liver function test electrolytes were within normal limits.
So, Dr. Dinesh, at this point, what all were your problems, your immediate concerns that you
Immediate
needed to?
concerns: a patient has come with fever with breathing difficulty. She is in distress. She is hypoxemic. She is having a high blood pressure, preeclampsia with severe feature, and she has a retained fetal demise. Babies inside her, so she might get worsen. And now she has lab investigations wise, she is having a bicytopenia picture with leukocytosis, and our other coagulation parameters point towards a DIC picture with the D-dimer elevation, iron fibrinogen reduced, APTT increased. So this patient may start developing a DIC. She might start oozing from her catheter insertion sites, gum bleeding, pervaginal bleeding. She might start, she might have, but she didn't have at the time of presentation.
So, immediate concerns and what you're potentially expecting. So, what is your immediate concern now?
Immediate concern: the patient has signs of pulmonary edema, so she can go into respiratory failure. She may require in the near can require invasive ventilation. She's having a DIC picture. The ISTH scoring was almost 6 points, so it means she has over DIC. So this patient will require multiple blood product transfusions. So the transfusion services have to be informed, and we'll have to get a multidisciplinary team involved, because the physicians have to decide on delivering the dead fetus, and the anesthesia team has to be informed, because the patient has currently having hypoxemia, might require prolonged ventilation if at all her respiratory status worsens. Other than that, I have to side by side rule out the other differential diagnosis that I had in mind. So I will start with sending blood cultures for ruling for
No,
counting
just 1 minute. So in this patient, in this clinical scenario, so you told like we have a differential diagnosis of sepsis, 1 point, okay, well accepted. And I don't think a community acute pneumonia will not be the cause at that point, because we had a sepsis from the like skin and soft tissue, then developing breathing difficulty. So what will be the possibility there rather than community acute pneumonia?
A skin and soft tissue infection that has triggered a sepsis cascade. So that could be
a sepsis cascade. Other than that, a skin abscess patient developing breathing difficulty later. What is the usual common organism causing skin abscess?
Staphylococcus aureus.
If a patient is having a staphylococcal bacteremia, how a patient can develop breathing difficulty?
When they develop a toxic shock syndrome, so when after
this is toxic with the BP of 150, 100, you want to think about toxic shock syndrome?
No, sir. They will have.
Other than that, anything the staphylococcus can do in the lung?
It can cause nematocele, sir. So
it's not nematocele.
Yes.
It can have, but it can. Then what will happen if a patient is having staphylococcal bacteremia? What is in particular to staphylococcal organism? Can have metastatic infections, and it can have. So what will happen to the lung? Where will you get nematocele? In which condition? You are near that point. It is not because of nematocele patient is developing breathing difficulty in staphylococcal bacteremia. Then what will happen in the lung? Staphylococcal pneumonia.
Yes.
Because of hematogenous spread. Okay, yeah, go ahead. So what is the other abnormal features here? Even if you suspect a sepsis or eclampsia or preeclampsia, what were the abnormal features there?
So another from the baseline investigations, the other abnormal features that I found was a bicytopenia with the leukocytosis, so at the time of admission, along with the cultures, we had sent peripheral smear. We had taken a chest X-ray. A chest X-ray showed a bilateral homogeneous opacities indicating pulmonary edema. But our preliminary reporting of peripheral smear we received within few hours, and it showed.
Just go back.
Okay, sir.
And I'm asking, with that clinical picture, you have a clinical diagnosis of like a PAH or a sepsis.
Yes.
So, what are the features which is unusual in that situation? Is this the same typical picture, or do you see any unusual picture that is not like seen in a patient with a like overt sepsis or like a eclampsia, which warrants further investigations at this point?
At this point, preeclampsia patients can develop pulmonary edema. They can present with this picture, sir. The outstanding
Do you
specific-
see any abnormalities than the clinical picture you described? That is what I wanted to know.
sir, the patient with preeclampsia with severe features can develop thrombocytopenia, but not to this extent. 40,000 patient with preeclampsia, once they develop HELP syndrome, the DIC picture is very rare. In the differential diagnosis of DIC in pregnancy will be preeclampsia, but it is not a very common cause. So a patient.
So here you see that the DIC is an abnormal thing, and
Yes,
the fall in hemoglobin also.
Yes, sir.
Okay, that is what you wanted to try to tell, right?
Yes, sir. Yes.
Anything else? What will happen to total leukocyte count? Do you expect such a leukocytosis in like if it is only a only a eclampsia?
No, sir. Mild leukocytosis is expected. 31,000
So the
definitely.
severe leukocytosis is another abnormal feature.
Yes.
So
there could be a
then
underlying.
what else could have been there? Like if the platelet is low, the total leukocyte count is increased. But then what else you expect in liver function test?
Liver function test, we expect increase in transaminases, decrease in albumin, especially in preeclampsia.
Any other investigations in
lactate dehydrogenase will be elevated. Even
LDH? Did you check LDH here?
At this point in time, we had checked. It was elevated. It's around 500, sir. The cutoff.
What other investigation again favoring a eclampsia or a PAS?
So other investigations, thrombocytopenia, renal insufficiency, creatinine we checked, sir.
Other than these investigations, you told LDH.
Yes, sir.
Along with LDH, in the PAH profile, is there any other investigation? I'm asking.
PAH profile.
What syndrome are you describing?
HELP syndrome, ma'am. So hemolysis, elevated liver enzymes, and low platelet count. So hemolysis can be evident with the presence of schistocytes.
Any significance of uric acid here?
Yes, sir. Uric acid will be elevated in preeclampsia patients. Yes, sir.
So those are the other investigations you have to do. Yes, if LDH is disproportionately elevated in this blood picture, yes, what else you will think about?
If LDH is significantly, I'll suspect hemolysis, sir, and I will send for a peripheral smear to look for fragmented RBCs. So preeclampsia can lead to hemolysis and this elevation, sir.
Okay. Yeah, go ahead.
This patient.
So what are the other investigations? Just go back.
Sorry.
Go back.
Complete blood.
No. Just that investigation slide. So you have a patient with 24 weeks IUD, patient in DIC. Okay, patient is having features of doubtful sepsis as well with breathing difficulty. So what is your further plan? Investigation management you want to do at this point, or how you are going to proceed?
Since this patient has a retained dead fetus in her, and the patient is having over DIC, so we have to assume that the DIC could be due to the fetal demise, and the fetus has to be evacuated. So we did a multidisciplinary team approach. We called in the OGCNs.
See, this is you are presenting the case. This is not like what you have done. We are not bothered. So you have just examined the case.
Yes, sir.
So just what is your examination finding, and what is your plan at this point? That is what we are asking.
My plan will be to send in the basic investigation.
What are the clinical issues and how you are going to tackle it?
Yes, sir. So my clinical issues. My current plan will be to keep in all the differential diagnosis in mind, and I'll have to plan to stabilize the patient with airway, breathing, circulation. The next plan will be to evacuate the baby, since the DIC could have been caused due to the.
So now that is the issue. So
Yes,
now
sir.
you want to take out the baby
Yes,
with
sir.
the DIC.
Yes,
So
sir.
that is the main issue. And the
Yes, sir.
patient is also having features of sepsis and,
Sepsis.
and having some unusual features which you cannot explain with the routine investigations. Anusha, please.
No, I wanted him to tell about that. How will you manage the sepsis part of this patient?
So
What is-
after sending cultures, I will start an empirical broad
Yeah, what?
spectrum
Which antibiotic?
antibiotic right now, since the patient is having fever, high blood pressure, and with 2 days, it's a 2 days history of just 1 day history of breathing difficulty. I'll start her on ceftriaxone, and with since we have a seasonal infection of influenza at that time, we started even on oseltamivir, and with atypical coverage with macrolide.
A patient with a skin abscess we have already discussed.
Yes,
You are suspecting staphylococcal bacteremia and you are suspecting a hematological spread and you want to treat that patient with ceftriaxone. So that is
sir.
what you mean?
No, sir. No, sir.
Then what is the main organism you want to cover at that point?
I want to cover skin and soft tissue infection. Gram-positive coverage I want.
Which organ? Forget about all those things.
Yes,
This
sir.
clinical scenario, which all organisms you want to cover?
Staphylococcus aureus, definitely, sir.
So Staphylococcus aureus you want to cover with ceftriaxone?
No, sir. No, sir. So Staphylococcus aureus I want to cover. So since the patient already had underwent IND with an antibiotic course, since the patient had already received an antibiotic course in the recent past, so I would want to cover with the anti-MRSA, anti-MRSA. So
which one will you use here?
Since this patient have profound thrombocytopenia, I cannot use linezolid. So I will start the patient on clindamycin.
Why you cannot use linezolid in thrombocytopenia?
Linezolid can cause further worsen thrombocytopenia.
When, like if you give immediately, it will give.
No,
it will
sir.
produce. Any other reason, like which anti-staphylococcus, anti-MRSA antibiotic you will select at this situation?
Since this is skin and soft tissue infection, I will my best my first option will be a linezolid. Then my next option will be vancomycin can be given, sir.
Why you want to suspect MRSA now?
Yeah.
Patient
You have
had
another drug?
Ma'am?
You have some other drugs which you can.
Excuse me, 5 minutes more.
Clindamycin. Clindamycin 600.
Yeah. Okay.
So a patient had recent IND with the antibiotic exposure, so that's why, sir.
So you want only like anti-staphylococcal coverage, nothing.
No, sir.
With already having IUD, and it can be the sepsis maybe because of that as well. So.
Yes, so I want a beta-lactam is inhibitor. Piperacillin, tazobactam, I'll start, sir.
Why?
Patient has. I also suspect septic intrauterine sepsis because of the IUD, so it has to be covered.
Okay, so how you are going to optimize now?
So now the patient. I will.
You want to assume something before taking up for the case, or you want to do some optimization and immediately rush for the case?
Sir, I want to I will want to evaluate the patient further, but since this patient is having already over DAC, I will push in for emergency evacuation, but I will have to monitor the coagulation parameters. So I will make use of point of care coagulation testing in order to transfuse appropriately manage the coagulopathy.
What point of care test at this point? You already have normal INR, increased APTT, low fibrinogen, thrombocytopenia, and low hemoglobin. If you want to correct at this point, how you are going to correct?
Sir, I would want to keep targets. So since this patient has unexplained anemia, so I will want to keep a target of hemoglobin of 8. So I will transfuse a blood product to achieve a hemoglobin of 8 and a platelet of 50,000. Fibrinogen is very low, so the less than 100 is very severe. So I will have to give cryoprecipitate. Cryoprecipitate. But
How much
since
cryoprecipitate?
Sir?
How much cryoprecipitate?
6 units cryoprecipitate, sir.
How will you decide on cryoprecipitate dose?
Mm,
Okay, you called up your blood bank for cryoprecipitate. They are saying there is no cryoprecipitate in that blood bank at that point. So whether any other drugs you can use or any other products or something you can use instead of
yes,
cryoprecipitate?
fibrinogen concentrates are available, and even 4-factor PCC is available. So instead of cryoprecipitate, we can those contain higher amount of fibrinogen, so that can
Just
be.
1 minute. So you want to use 4-factor PCC to cover for low fibrinogen, you mean?
No, sir, not only for fibrinogen.
So
What is there in 4-factor?
8, 13 fibrinogen, and
Are you sure?
you have fibrinogen also in 4-PCC?
No, sir, no.
Then
Fibrinogen.
you want to still go with 4-PCC or one
No,
more
sir.
drug you told before?
Fibrinogen concentrates, sir.
So how much fibrinogen concentrate will you use? Dose?
Sorry, sir, I don't.
Okay. So only fibrinogen concentrate is enough. What are the other coagulation abnormalities? How you are going to correct?
Other coagulation parameters. So
The patient
patient
is
has to be
thrombocytopenia. Patient is having elevated APTT.
platelet concentrates also. Single donor or random donor platelets. So since this patient has
How many units SDP?
a single donor platelet will increase the platelet count by 40,000, 50,000, sir. So
How many units you want?
I would want one right now, sir. One
Okay.
is
What about APTT?
APTT is 33.5. So
So how will you correct prolonged APTT?
INR will be corrected by fresh frozen plasma.
APTT?
APTT.
What is the difference between APTT and INR in a coagulation profile?
INR indicates
If APTT is prolonged, INR is normal. What does that indicate?
INR indicates extrinsic system, APTT indicates intrinsic system. So prolonged APTT, we usually see a patient on heparin.
Only on
Prolonged APTT.
Any other cause?
Time's up.
Or
Sorry.
Okay, so that like that answer also you can do. This is a patient with pregnancy. You forget about all other things. You are getting only isolated APTT elevation. So, do you think any other cause? Patient has a breathing difficulty also. You suspect which one?
Antiphospholipid syndrome.
What all investigation you will send out confirm whether the patient is having an APLA?
Sir, three antibodies. So lupus anticoagulant, anticardiolipin antibody, IgM, IgG, and beta-2 glycoprotein IgG and IgM. So
before sending that, and the patient is having already elevated APTT, in the previous drug history, because the patient was referred from outside, will you see whether the patient has received any other drugs? You only told before which drug can cause APTT elevation.
Heparin can cause APTT elevation.
Okay, so you have to correct all these parameters. Then, along with that, what other things will you do to optimize the coagulation?
Sir, since this patient will go in for DIC, since the patient has DIC intra-op and post-op, they may go in for severe transfusion requirement. So I will keep a transfusion blood bank ready, and I'll transfuse in the ratio of 1:1:1 if at all required. So and then use thromboelastography if
Forget
yes,
I've agreed about blood products.
yes, sir.
Other than looking at blood products,
Yes, sir.
any other things will you see whether it is correct or not? Because to prevent the bleeding in a coagulopathic patient or in a trauma patient, you are getting a profusely bleeding trauma patient. So
Acidosis,
what are the other things?
hypothermia.
Yeah, good. Come on.
Acidosis, hypothermia, I will have to keep in account. So I will have to actively.
Anything else? Temperature you have to maintain. Okay.
Yes, sir.
Acidosis to prevent. One more
Yes,
point. Any electrolytes you have to see?
calcium, sir.
Okay.
Calcium will get depleted.
Good. Okay. Anything, Anusha? Anything?
Yeah, we should proceed. Yeah. Yeah, we should proceed for debriefing, I think. So, Dr. Dinesh, we'll start with you. How did you feel?
I feel
Answer.
yes, ma'am. It was little difficult, but I'm yet to reach that level of understanding and the management of cases.
Okay.
Some idea of, for example, choosing antibiotics, I'm little weak. So approach to case, I could analyze and I could understand, but some flaw, some issues are still there to improve.
I think you did all right for us. First year, you're just finishing, right?
Yes, ma'am.
So, I think Dr. Anoop can debrief first then.
Yeah, one thing like this is only 30 minutes case presentation and discussion. So in that, obviously, like whatever you have presented is well and good, but you don't have to tell about all negative points unless and until an examiner is specifically asking you. Otherwise, you won't get any time for the discussion. So only the relevant positive things in the history or like in the past history, and then the investigation, what is the things, with that, what is your clinical diagnosis? That is the thing what we expect rather than going for all negative, just like the way you present for a like MBBS medicine. We don't want this thing or those things. Like immediately, what are the issues you are seeing? What are the findings? And then you decide what are the differential diagnosis. Based on that, how you are going to proceed. So here, the issues you should have identified. One thing well and good, the PAH. So what all workup you have to do for the PAH, how to optimize that. Then anyway, you have to do the evacuation. So when the patient with a coagulopathy, how to optimize that, and then you have to taken for the taken for the surgery. So that part I think you have done well, except for the 4-PCC and fibrinogen concentrate, you got a bit confused. So whenever you you tell something or you take the examiner to that point, so you should have a clear-cut idea. The same way the fibrinogen dose, cryoprecipitate dose, how to calculate, and each other products like 4-PCC, what are the contents is very basic. Then the fibrinogen concentrate, the contents, and again like whenever the patient is having some abnormal DIC, how to evaluate and correct that. So that is one point I think you have missed. So whenever patient is having something which you cannot explain with these investigations, and when you are taking up for a procedure, even for the medical legal purpose and for convincing the relatives, you should have ruled out any other causes which can produce DIC in this patient. Like in your next slide only, you are showing the ATRA, all those things.
Yes.
So it could have been an hematological malignancy. So that also you should have told. So I will consider other possibilities like hematological malignancy, because there are some unusual features which cannot be explained with only these features, like at least looking at a peripheral smear. That should have been emphasized, I feel.
Yes.
Then after suspecting a sepsis, especially skin and skin abscesses, patient developing breathing difficulty with a high-grade fever, first thing that should have come to your mind should have been a staphylococcal bacteremia with like a staphylococcal pneumonia and other complications, including like an infective endocarditis, all those things. So you should definitely do a blood culture, which you have never told about blood culture. That also you should have highlighted, because I have to send the culture before initiating an antibiotic or along with initiating antibiotics. And while selecting an antibiotic, your main concerns, one is a staphylococcal bacteremia or a gram-positive organism. then definitely a patient is with an IUD definitely can get a gram-negative sepsis also. So that is why which antibiotic combination you have to select. And one other mistake like toxic shock syndrome you told. So that patient should have a shock. The BP should be low. So with such a high BP should never like tell the possibility of a toxic shock syndrome. Then other thing like another one mistake you have done is like your room air saturation was only 90%.
Yes.
Then you were using 4 liters to get a saturation of 96. That will not happen. If a room air saturation is 90, you may not require that much oxygen. So it's not that hypoxic. So those minor mistakes you could have avoided, but altogether you have done well. Only thing, so much negative history, very detailed, the point discussion in the initial part. So you didn't get enough time for the case discussion, but even altogether you have done well. And again, whenever you tell about the coagulation correction, definitely the temperature, the calcium, the pH, all those things should have been mentioned. Anusha, anything more?
Yeah, so what I thought was, I think you did well. The way you progressed was good. But basically, you need to concentrate on your basics. So as soon as this patient comes, you're almost, I mean, when we examine, we are going to see whether you are a safe person. Are you going to safely take this patient across in the ICU? So for that, you need to first prioritize what are the immediate life-threatening problems in this patient. And like sepsis and all are like bread and butter. So you should, in any ICU, so you should know what are the antibiotics. This is the clinical syndrome I have. So this is the drug I want to start immediately. And if you know, I mean, you will get used to it. So you will know the bundles. So what you should do immediately when you suspect sepsis, these are the things I'm going to send out. This is the antibiotic I'm going to start. So there are like groups of like kind of syndromes that you can say, okay, this infection comes, I will start this. And what are the contraindications for that? Anything else I can do for that? So, and then look at ABC, always prioritize, finish that off. Then you know that patient is safe now. Then you can go for more complicated diagnosis like TTP and all you're coming to that. So once we know that you know the basics, you took care of the airway, hypoxia is there or not. So all that, if we can see that you're looking for all that, then you can go for, and then you'll lead your examiners in the right path, like what you want, what you have prepared for. So otherwise, I think, I mean, you'll get used to all this. So otherwise it was good. Yeah. Thank you.
Yes.
So,
So for others attending this session, like if you have any comments or like any other suggestions, or if you want to discuss any other points, please put it in your comment box or chat box. That we'll take and discuss after the next case. So Dinesh, thank you so much. You've done well.
thank you.
So update your knowledge and keep reading. Okay. Thank you so much. Over to next presenter.
Good evening, one and all. So I'm Dr. Swati, second year DM resident, Department of Critical Care Medicine, IMS and Sam Hospital, Bhubaneswar. This is a case of 45-year-old male, former by occupation, resident of Angul district, Odisha, came to our hospital with the chief complaints of fever since 5 days, difficulty in breathing since 4 days, and cough with expectoration since 3 days. Fever is low grade, initially 1 to 2 episodes, progress to continuous over 2 days, non-documented, not associated with chills or rigor, not associated with rash, subsided with paracetamol. And difficulty in breathing is sudden in onset, difficulty in doing daily activities like going to washroom, followed by shortness of breath at rest for last 1 day. And cough is sudden in onset, productive in nature with yellow, scanty and mucopurulent sputum. It is not blood stained. And cough is not associated with any diurnal or postural variation since last 3 days. There is no history of chest pain, difficulty in breathing or lying supine, disturbed sleep, palpitations, giddiness, blood in sputum, swelling of extremities, decreased urination, no burning sensation or burning during pain during urination or urge to urinate. And there is no history of nausea.
Just 1 minute. You might have listened to the previous discussion. So come to the positive finding alone, skip all the negative things.
Okay, sir. He is a 45-year-old male with chief complaints of fever since 5 days. shortness of
You
breath.
don't have to repeat it. Come to the examination part. What are the positive things in the investigation exam? Then we will go for the discussion.
Currently, patient is on day 3 of ICU stay. General examination, patient is well built and nourished. Weight 60 kgs with the height of.
Skip all those things. Relevant point only. You have already intubated the patient.
Yes, sir.
The patient was okay. We came with a breathing difficulty and was intubated.
Yes, sir. Yes, sir.
So what was
He's on
indication?
day 3 of ICU stay.
Okay, what was the indication for intubation?
Patient was shifted to ICU with complaint of worsening shortness of breath and desaturation with saturation of 90% with 10 liters of NRBM. To improve his oxygenation and also to decrease his work of breathing, we have intubated him.
No, just 1 minute. A patient if is on 10 liters of oxygen, that is the indication to intubate, or will you try something else before that?
We can try for non-invasive ventilation or high flow nasal cannula.
Why you have not tried that?
Because if patient is according to this Kegel's modification, SpO2 by FiO2 ratio is less than 315. Patient is having so I want to intubate him, sir. I don't want to wait.
What are the contraindications for NIV generally, non-invasive, that you didn't consider non-invasive?
Contraindications for patient is restless. He's restless, and he's so contraindication. Non-invasive ventilation because
just see, suppose this patient is coming to your ICU, shifted from the emergency department, a patient with fever, breathing difficulty. The patient is shifted with NRBM on 10 liters of oxygen. So immediately you decide to go ahead and ventilate. That is what you are trying to convey. Or usually when a patient is coming to the ICU, how you manage that patient?
Usually means actually this patient
you forget about this patient, and now a patient is coming, you are on duty, so a patient is being shifted from the ED with a history of fever, cough, breathing difficulty. No other investigation reports are available. Patient is on 10 liters per minute oxygen. So what all other things you assess at that point, and how will you decide to go ahead with invasive ventilation, or if not going for invasive ventilation, what all things will you try at that point? And then if you are trying something like an NIV or HFNC, how will you decide when to convert to an invasive ventilation?
Generally, if this kind of patient comes to our ICU, I will give a non-invasive ventilation trial or high frequency nasal cannula.
Before that, your patient, sir, Dr. Anoop was asking, patient has come with NRBM. How will you assess whether patient needs to escalate to another mode of ventilation? Patient has just come with NRBM 10 liters.
First, I will see for airway whether he is able to protect his airway. And then the breathing, how is his breathing? Shortness. Patient is he using any? Is there any nasal flaring or using any axillary muscles for respiration? Is it then circulation? How is his heart rate? How is his blood pressure? Is there any? How is his capillary refill time? How is his? Is there any mottling, which is like, is there any circulatory failure? I will take care of the things, and at last, I will assess his sensorium, whether patient will be able to. This
patient is fully conscious, obeying, and hemodynamically stable, but having a tachycardia heart rate of 108. What other investigation will you do, and how will you proceed?
Other investigations, I want to do arterial bed gas analysis to see for his pH PCO2, pH, partial pressure of carbon dioxide, partial pressure of oxygen, bicarbonate.
In this
and
patient, what will you
that is-
expect with PCO2?
In this patient, as a patient is having tachypnea, I will be expecting respiratory alkalosis. So PCO2 will be less in this patient.
Then, so you have taken the
And then I will do one chest X-ray, and also I will do one bedside focus of lungs and heart to see whether it's a cause of it's a cardiogenic or non-cardiogenic. And I will assess. I will see for any shreds.
from the
or
history wise, what
lines.
are the points against cardiogenic the cause?
In this patient, in my patients.
Yeah, your patient.
Yes. So in my patient, against cardiogenic is patient 2D echo. The focus finding 2D echo was
No, the history wise I am asking.
history wise. Patient is having shortness of breath. That is very of 4 days onset. That is very acute, which is like. And one more thing is patient is having cough with expectoration. With expectoration is not expected in cardiogenic.
You will not
cause.
get expectoration in cardiogenic cause.
And patient is having yellowish secretions.
Other than that,
And the patient is
patient had a high grade fever. So whenever the
high-grade
patient is
fever,
having a
so-
high grade fever, cough, infective etiology will be the first possibility. Obviously, that patient can have a cardiac cause also, but in that situation, infective etiology will be the first thing. So you have taken chest X-ray, you have taken an ABG. What other investigation will you send at that point?
at that point, I will send complete blood picture.
No, that's okay.
Yes.
Other than routine investigations,
Anything specific for this?
specific this case.
What are you suspecting?
I'm suspecting in the community echo and pneumonia in this
So
patient.
what will you do?
I will send sputum for culture and sensitivity, and
Only that, no other test.
Is it a sensitive test?
This patient is coming to your Bhubaneswar ICU with fever, cough, breathing difficulty, suddenly worsening breathing difficulty. So you are sending all investigations. What
ECG. I want to do one ECG also, sir.
Okay, ECG is the sinus tachycardia alone. Any other specific investigations when you are suspecting a pneumonia? Only sputum culture, nothing more. Any viral infections can cause this similar picture?
Yes, sir.
What are the viral infections which can have a similar picture like this?
Viral infections, dengue pneumonia can cause this, or any
This is a
COVID
dengue-
pneumonia
no, wait,
or
wait,
influenza pneumonia.
Wait.
Yes.
But this is a patient with a fever, breathing difficulty. Dengue is the first cause you consider.
No, sir, no.
So what are the common cause?
Influenza virus,
Hmm.
human influenza virus, or any COVID pneumonia.
Okay, good. So what test will you do?
So RT-PCR can be sent for these patients.
Hmm.
So, but there is no, like, patient is not in endemic. There is no pandemic or endemic. It's not an Odisha is not an endemic area, so we have not sent for RT-PCR initially.
Orissa is not a center for what? There is no COVID and influenza in Orissa.
Means no, at present incidence less.
Less only, no.
Yes, sir.
Yeah, but still can be a possibility because in India we have all the states are having increased COVID number and influenza also reported from everywhere.
Everywhere.
So definitely you have to screen for both. In influenza particularly, what test will you ask for? What PCR?
RT-PCR
What influenza RT-PCR means?
H1N1.
You ask for only H1N1. What other influenza you know?
H3N2, that is bird flu.
Then H3N2 is bird flu.
Any other influence?
Other common influenza in India? Okay, forget that. So this patient, you send all the viral markers. Anything else? Chest X-ray you have taken. Patient with fever.
Tropical fever workup is done, sir. Tropical fever workup, that is for dengue, scrap typhus,
Okay.
leptospira, and malaria. We will be doing. So
What is sent for that? For scrub typhus, what is?
What
scrap typhus, we will be sending scrap typhus IgM.
will you send in this
antibodies.
patient? Patient with 3 days history of fever, breathing
Yes.
difficulty,
Yes,
IgM antibody for scrub typhus.
yes, yes.
Will it be positive? Even if it is a scrub?
No, sir. There might be some false negatives in this patient.
Why?
Antibody titer, increase in the titer will take time. Like,
Okay, fine.
to
Okay, that's
get
good. Okay.
positivity.
So you have to send all the routine investigations, fine. So you have sent all the investigations. Okay, now how you are going to manage this patient? Not this patient, you have given the scenario, no? Patient with fever, breathing difficulty, 3 days fever cough, shifting from emergency department, a fully conscious patient, hemodynamically stable, having temperature spike. Now with 10 liters of NRBM, saturation is 98. Respiratory rate is 36. So how will you manage?
Saturation is 98 and respiratory rate is 36, sir.
36.
10 liters of NRBM. So I will give an NIV, non-invasive ventilation trial to this patient, sir.
Okay, then when will you see that, when will you decide that your NIV is failing?
After 1 hour of NIV trial, I will do ABG and see if there is any worsening. If the patient is symptomatically improving and if there is any worsening of oxygenation, and based on that, I will decide whether to intubate the patient.
Any scores, which you can see? Or if you know the components of the score is fine.
You're putting the patient on HFNC or NIV, even during COVID time, any score you can use in the ICU,
Yes,
any
sir.
index? What is ROX index?
ROX index is used for HFNC, sir. After 2 hours of HFNC, we will
After
be
2 hours only you can do it ROX index?
At 2 hours, 6 hours, and 8 hours.
That depends on the scenario. Like if the patient is sick, you can do it at 30 minutes also. So how will you do? That's what she was asking. How will you calculate ROX index for this patient?
ROX index is calculated with respiratory rate into SpO2 by. Actually, forward that.
Okay.
FiO2.
Yeah. And I know about Hacker score?
Yes, Hacker score, hypoxemia, age.
Age.
Yeah.
Okay, fine.
Okay, so you have put the patient on NIV. So by looking at you have put an ICU ventilator NIV. So what are the parameters you look at that? How the patient is tolerated? You forget about all the scores.
Scores, yeah, they are basically that only.
So you put on like an NIV in your ICU ventilator. So what are things now you assess after putting clinically? By looking at ventilator, then by looking at the patient, by looking at the monitor.
By looking at the patient, I will see if the patient is tolerant with the NIV, whether he's compliant with the NIV, sir, whether he's allowing to put it, and if there is any nasal flaring or using accessory muscles. And patient,
you decide the patient is failing NIV by looking accessory muscles and nasal flare and all. Can you see a nasal flare after putting NIV in an ICU patient?
No, sir.
And then
So,
what you
use of-
usually, no, you cool, you don't, this is not an exam, no, so relax. So just think you are in the ICU, you are getting a patient, you have put the patient on NIV in an ICU ventilator, what all settings you do in the NIV, and when you are worried, like which parameter, if it is going too high to maintain a saturation and all, you will be more worried. Or like again, the patient, if it's not tolerating, what other clinical features you can make out. Simple things.
simple things means,
Very,
in
very routine things
monitor.
that you are assessing in the ICU.
In monitor, I will see if there is any saturation, fall in saturation.
Okay.
If there is any increase in the respiratory rate.
So
Or
your nurse has put the patient on 100% FiO2. You are happy with that?
No, sir.
Saturation is 100%.
No, sir.
That's why you have to look at FiO2 requirement. The requirement is too high. That itself is an indication to go for an invasive ventilation. Then monitor. If the patient is tolerating, what all change you can see in the monitor?
There will be heart rate will be normalizing. Tachycardia will
So
settle
the
down.
tachycardia will be coming down. If they're not tolerating, patient will become more, developing more tachycardia. There will be more diaphoresis. So those are the clinical things you have to assess.
And sensorium also. You have to keep
Yeah,
a watch
actually.
on the sensorium.
So this patient was like not having a high oxygen requirement, becoming restless, diaphoretic. Your FiO2 requirement was going high. So you decided to tube this patient. Okay.
Yes.
So what are your, like this patient is already on say 70% FiO2 or 80% FiO2, you are hardly getting 90 saturation. So when you have discussed with your consultant, you have decided to go ahead and ventilate. So how will you ventilate that patient?
FiO2 of 90, sir.
FiO2 of 80, patient is saturating hardly 90. So now you have decided to ventilate this patient. So how you are going to ventilate? How will you maintain the oxygenation? How will you ventilate?
First, I will increase. First, I will see for first. I will measure the patient's predicted body weight, sir. So to set a tidal volume. Generally, we will be. I will use pressure control ventilation in this patient. I will generate.
Before ventilation, you have to tube this hypoxic patient. No, I'm asking about that.
How will you intubate this patient?
How will you intubate this patient?
First, I will pre-oxygenate the patient. First, I will take the informed consent from the relatives.
That's okay. Forget about all those things. Just come to the clinical side. Somebody has taken all those things. Consent, discussion with the relatives. Everything is over.
Okay, sir. Then first, I will pre-oxygenate the patient with already he is on NIV. So,
yes.
So I will load the induction drug. I will my drug of choice here will be.
How will you pre-oxygenate?
Already patient is on NIV, so I will increase the FiO2 to 100, sir.
Okay, good. Then
FiO2 to 100, and I will load the induction drug.
Okay, everything is ready. Your nurses are excellent, so they kept everything ready. Your respiratory therapist is also side by, so everything is ready. So you have to just proceed.
So I will do a rapid sequence induction in these patients, sir.
So
Fixed dose of I will give fixed dose of propofol and a fixed dose of propofol, that is 2 micrograms per kg body weight, and a fixed dose of vecuronium 0.1 mg per kg body weight. And also I will give analgesia injection fentanyl 2 mics per kg body weight. After that, I will do laryngoscopy and intubate the patient with 8.5.
The patient was on NIV, spontaneous mode.
Spontaneous mode. I will ask a sister or someone to change the ventilator setting to control mode. And during that time, I will do laryngoscopy and intubate the patient. Intubate the patient and fix the ET tube at. He's a male patient, so I will fix the ET
So
tube.
everything is done. Everything is done now. The patient is on ventilator. So now with the 100% saturation, what are the settings you are going to keep now?
I will keep the patient on pressure control ventilation mode with a FiO2 of 100, and I will set PEEP at 14 mm of initially at 14 centimeters of mercury, and the respiratory rate I will keep at 30 per minute, and peak inspiratory pressure, and see how much tidal volume patient is taking. And based on that tidal volume, like I want to maintain a tidal volume of 8 ml per kg body weight. So based on that, I will set the inspiration PEEP.
What tidal volume?
Pressure.
You want to revise your tidal volume?
You want to still keep at 8 ml per kg?
8 ml per kg, and see, I will see the plateau pressures, and if it is less than 30 centimeters of water, I will continue with it.
So you have put a pressure patient on pressure control mode, you told. So how will you look at plateau pressure now?
The peak pressures which are visible on the monitor generally correlates with the pre-plateau pressures. In this kind of patients, so plateau pressures, so that we will be considering as plateau pressure. And
so in our pressure control mode, that was the question. How did you set the tidal volume? You were saying 8 ml per kg, right? So you need to.
So based on the, I will be setting the pressure, inspiratory pressure. Inspiratory pressure, and I will be continuously. I will see how much tidal volume patient is taking.
Okay.
Based on that, I will ask the sister. I will give a target that you have to monitor this amount of tidal volume, and so it's like continuously they will be monitoring the tidal volume which we have set.
And what inference or what change in your pressure control will you make by looking at plateau pressure?
By looking at plateau pressure, I will be.
You kept it. You wanted a tidal. Say this patient was 50 kg. So you told your sister to keep it 400 ml. So she kept she was keep on increasing the pressure. So now the patient is at like your the plateau pressure is coming at 36.
Plateau pressure is coming at 36. Then I will try to.
You kept a PEEP of 14 also. So now with the 8 ml your plateau pressure is coming 42.
Then I will give a trial of changing the mode to volume control to generate adequate tidal volume.
What volume? So 8 ml she has kept at 400 ml again. So now again the plateau pressure is showing 42. So you told that to change, your respiratory therapist changed to 400 ml tidal volume, the volume control mode with 14 PEEP. So it is still showing the same plateau.
Dr. Anoop, 5 minutes more.
Okay.
So what is causing this pressure to go up?
Poor compliance is causing the pressure to go up, ma'am. So then at this point of time, I will try prone ventilation.
Immediately decided to prone.
First, I will like.
So this patient, just 1 minute. This patient, before proning, how can you improve oxygenation by changing the ventilatory parameters?
What are the ventilatory settings that will determine oxygenation?
Oxygenation is determined by FiO2, and also PEEP, amount of PEEP we are giving, and also respiratory time. So I can try changing I/E ratio to 1:1.2.
1:1.2.
1.2 to 1.3.
Okay, you don't want to keep 1:1. Okay, fine. Then how will you titrate PEEP now? Still, you want to keep at 8 ml only, even if the plateau pressure is 42.
I
You want 8
can
ml.
now. I will no, every based on the patient's response, I will try to decrease 1 ml per kg body weight up
Based
till
on-
maximum till.
Based on what response?
Sir?
Based on what response will you reduce? Like you will reduce the tidal volume.
Based on targets, like I will see for oxygenation, PaO2, I will try
Based
to
on
maintain more
based
than
on
10.
PaO2, based on PaO2, you reduce tidal volume.
Based on the
Said the
plateau pressure,
oxygenation is different. Yes.
plateau pressures, I want to reduce the tidal volumes.
Okay, what plateau pressure you are aiming?
I'm aiming 30 centimeters of water of plateau pressure.
Any
So,
other pressure you are worried about at this point other than plateau pressure?
driving pressure, sir.
So how will you calculate driving pressure?
Driving pressure is calculated as a P plateau minus P. So
how much driving pressure you want?
I want to maintain a driving pressure less than 14 centimeters of water.
So how much is it now?
This is 14 PEEP and 42
42.
plateau.
42 minus, it's a 28.
So you want 28 driving pressure with 400.
No, sir. No,
So
sir.
how will you reduce the driving pressure now?
So what do you mean by driving pressure? Any idea?
Driving pressure, it indicates the as the complaints of the lung increases driving pressure, then there will be an increase in the driving pressure. So it indicates the actually stress and strain in the lung. So
Okay, that's all complicated sentences. So what is the PEEP actually doing now for your driving pressure? It's the difference between plateau and PEEP, right? So what is your PEEP doing? Why do you keep PEEP in ARDS patients?
in ARDS patients, we'll give PEEP because PEEP, one thing is to increase ventilation in the
Is it for ventilation?
And to decrease the to expand the collapsed alveoli. I want to give PEEP in these patients, and also to improve the decrease the dead space ventilation, and also to increase the decrease the shunt fraction. So I want to give PEEP in these patients, ma'am.
So now you have increased your PEEP and your driving pressure has increased. So do you think this PEEP is helping your patient or is it worsening it?
It is worsening, ma'am. It is worsening the patient. So then
how will you titrate your PEEP now?
Now I want
Simple
to
way. Forget about all sophisticated methods. Simple way. How will you titrate?
Bedside.
Now I will decrease the bedside. I will decrease the PEEP and see for the see how much.
You are still keeping the tidal volume at 8 ml per kg. Okay, that you have to keep in mind. Do you want to make any change there in that?
I want to decrease the tidal volume.
Yes.
First, decrease the tidal volume and see, sir. So
okay.
now by
you have reduced the tidal volume now somewhere around 6 ml per kg or even slightly less than that. So now how you are going to titrate? Now your plateau pressure is say 38 and you are at a PEEP of 14. And with now with 90% you are getting a saturation of 98.
Then I will come down with the PEEP, sir, because this patient is not responding to PEEP. So
so what are your goals for your this ARDS patient? What SpO2 are you targeting?
SpO2, I will target SpO2 of 85 to 92%.
So how much is this patient at? This patient is at 98%, right? So you want to do anything?
And you've reduced PEEP to from 14 to 12, right? Or even further you reduced?
Yes, sir.
Reduced to 12.
As far as he is maintaining a saturation of 88 to 92, I want to reduce the PEEP, sir.
So how will you titrate the PEEP? How will you decide at what level of PEEP you have to keep?
First, I will reduce the PEEP by 1 centimeter of water and see for the saturation. And at the PEEP where the patient is maintaining a saturation of 92%, I will consider it to be the optimal PEEP for this patient. So I will.
So you look at only saturation and decide PEEP, or will you look at any other parameters?
I will even look at the partial pressure of oxygen in the ABG.
That's okay. PO2 or SPO2, you look at only that, or will you look at any other ventilatory parameters? Like look at.
Yeah, I will look at even
Mechanics.
P plateau and also driving pressure simultaneously.
Any mechanics of the lung?
Compliance.
Compliance means plateau indicates compliance. So yes.
So you don't look at compliance at all, or forget that also. By looking at compliance, if you want to adjust the PEEP, how will you do that? Okay. Any other methods of PEEP titration other than PEEP of best oxygenation you told? Other than that, any method by which you can titrate the PEEP?
One is ARDS FiO2 PEEP titration method.
Okay.
There is driving pressure.
Heart protocol, you can just titrate. Okay, accepted. Then
one more thing, one more is driving pressure guided ventilation method. I mean guided one, and one more thing is based on looking at loops in the flow volume loops in the ventilator.
how will you look at flow volume loop and decide on PEEP?
Any other loop?
I mean pressure volume loop, lower inflection point, and if there is any over distension.
No, you look at lower inflection point and then keep the PEEP at that point.
Yes.
Any other point? What is lower inflection point?
Lower inflection point is the pressure at which alveoli get opened up.
Yes.
At the end of at the starting of inspiration.
Okay. So here, what is your aim? You want to start opening, or you want to keep it open?
I want to keep it open.
Keep it open. So LIP is not the one. So the other one, other pressure. What's the other pressure you see in?
Higher inflection, inflection point, upper inflection.
Okay, now like your consultant is also into the scene, so he has optimized all the ventilation, and after that he left. So when will you decide to prone this patient?
I will consider early proning, sir. So when the patient's
when you early or late, whatever it may be, when you will prone. Early means now it's an indication.
Now it is an indication that we have tried everything. So I want to prone this patient.
No. Now what like this? Your consultant he has come and he has changed all the settings, and now the oxygenation is slightly improved. So how much oxygenation should be there, or when you decide to prone the patient?
When the patient's PF ratio is less than 150.
PF ratio less than 150, you prone?
Yes, sir. I didn't get the questions.
No. Whenever a patient's PF ratio immediately after intubation, if it is less than 150, you decide to prone that patient. That's what I'm asking.
No, sir. No, sir. First, I will try with changing ventilatory settings, and even after trying with this, if the patient is
Okay,
not
other
responding,
than that, other than any simple this thing, all patients with less than PF ratio 150, you will decide to prone?
yes, sir. We can prone these patients with PF
That
less than
any
50.
patient we can prone. That I'm asking. Like usually in your practice, all patients in your ICU PF ratio less than 150, you prone the patient.
Not all patients, sir. Depending on the patient. First, we will try changing the ventilatory settings and see.
The ventilatory
We will
settings,
trial for one
ventilatory
hour.
settings all changed. Now your PF ratio is coming as 140. So immediately you decide to prone.
Yes. First, we will give, if the patient is sedated and paralyzed, sir.
This patient is already sedated, paralyzed.
Okay. So then we will do proning to this patient.
This patient is already on 50% FiO2 and the saturation is 96 on a PEEP of 10. PF ratio is 140.
No, sir. No, sir. With saturation of 96%, we won't prone these patients.
Then what FiO2 you look at and what SpO2 you want usually? Roughly.
Usually FiO2 more than or equal to 0.6 and saturation if it is less than 92%.
Okay, so you have prone this patient, still the hypoxia is not improving. So is there any other method of improving the oxygenation? Even with the proning, the patient is on 80% oxygen. The saturation is hardly 90. You did a PF ratio, it is coming as somewhere around 50, 60 hardly. So is there any other method other than ventilation which can improve the oxygenation? Any other rescue methods?
Rescue method means we can try for recruitment maneuvers.
Okay, how will you recruit this patient?
Recruitment maneuver is done with pressure control kept at 40 and PEEP kept at 16 centimeters of water and
16 PEEP and 40
for 30 seconds it is. Sir?
16 PEEP and 40 pressure control.
Yes, sir. Means for pressure control with PEEP.
16 and 40. Okay, then what will you do after that?
It is given for 30 seconds and we will see for a response if the patient oxygenation is improving. And during that time, even we will be seeing for any hemodynamics.
No, anything else? I think we'll conclude, Anusha. Anything else? Anything more you want to ask?
No, I think we are exceeding the time. Otherwise, there are some more.
Yeah. Thank you, Swati. I know we know that you are a second year student, but still, if the audience also wanted to get like how the examiners will ask the questions. So just to get that feeling only. So really sorry that we have troubled you a bit. So don't worry. So this will be the way the examiners will be asking the questions. Okay. So in your case, I told you, you have to after briefing. So like after like a patient coming to ICU with an NRBM, don't immediately go and tube the patient. You have to try other NIV. So definitely you should know when you will decide to tube the patient or when you will how you assess the NIV tolerance or how will you know whether NIV is failing. That part you should be very clear. And how to tube a hypoxic patient in an ICU, so that you should be clear. That part I think you have done it reasonably well. But after tubing, you know how to titrate the PEEP and don't say the 8 ml per kg tidal volume and all. So that again, so those comments will be something like harming the patients initially itself by tubing the patient, all those things. So that should never happen. The Anusha was telling you, So even if you do some mistake, that's fine. But the major mistakes which is going to harm the patient, like examiners won't give you marks in that situation. So that you should be very careful and definitely you should go and read how to titrate the PEEP, what are the different methods, how to titrate based on compliance. So what is the titrating up, titrating down. those methods. Those are the basic ventilatory tips in an ARDS management. So that you should be very clear. So actually, we could have asked many other questions, but you were stuck with the basic ventilation itself. Okay, so that you should be very clear. Anusha, over to Anusha.
Yeah. Thank you, Dr. Swati. I think you did well for a finishing first year student. Like Dr. Anoop was mentioning, no, you can see that we actually got stuck. We didn't even proceed beyond one point in your examination itself. The first 3 lines, we are stuck there. So this is a ARDS case. It is very predictable, actually. You will be able to, you can almost think that this is how it is going to come. And these are the standard questions. So you just need to concentrate on what kind of ventilation is best for the patient, what is safe. And there are some landmark studies in this. So if you know, and you can tell that this study, they found this, like Dr. Anoop was asking, when will you prone this patient? And those kind of things are like fixed standard questions. So those things you should know, like 1, 2, 3, 4, 5, like that. Now, after this question, this only will come. You will be asked, this patient is desaturating, what will you do next? So you should know what. So you have put on ventilator. So how do you set it? So these are like 1, 2, 3, 4. So it will be easy for you. Once you start managing more patients, you go read what you're doing. Just what you do in the ICU is exactly what we are going to ask in the exam. So it will almost give us an idea that you are actually working with these patients. So that is how it is going to be. Don't think that we are going to ask outlined questions, hi-fi questions and all. But if you are managing these patients, you will be able to tell these 1, 2, 3. Like I think you are well versed with intubating patients in the ICU, so you are able to tell that quite well. So like that, you can slowly improve on ventilator and all. And the more things are there in ARDS, like ventilator is one part, how you manage the fluids. So many more things like that are there. And then what are the regular things that we do in the ICU? So we have to still come into that. So don't get stuck in one point. So that is what I would say. Otherwise, it was good. Yeah, you can just brush up on some of your basics, no? So that is.
Yes, ma'am.
Thank you.
Yes, ma'am.
Yes, thank you, Swati. So now I think Anusha will move on to the questions in the chat box. There are a few questions. Any other questions are also there? You can put it in the chat box now.
Audiences wanted to know that what's more important, driving versus peak pressure. One of the answers we have got in the chat box only, but you can proceed if you want.
Okay.
So,
Yeah.
what's more important, so driving versus peak pressure?
Yeah. From that point onwards, we'll come down. Anusha, you can answer that.
Okay. So basically now, nowadays we are concentrating more on the driving pressure than actually the question is peak pressure, right?
Driving versus peak pressure.
Peak pressure.
Yes, ma'am.
So,
it's peak pressure.
Usually, we in terms of now, when we ventilate a patient with ARDS, our main aim is we should not cause volutrauma or we should not cause barotrauma. So these two are basically because of the plateau pressures or the mean airway pressures. When it goes up, you have these problems. Basically, peak pressure comes when the resistance also is increased. Like in a bronchial asthma, you have peak pressure as well as plateau pressure. Both when they go up, the peak pressure increases. Or if it's only because of the compliance which is coming down, then plateau pressure will go up. So the total peak pressure will be due to the plateau pressure itself. I hope I'm getting that right. So right now, earlier they used to only concentrate on the plateau pressure. It should be less than 30. So we used to give PEEP and all. And most of the time, if you see most of the previous studies, if you see, they were giving higher and higher PEEP and there was no mortality benefit. Then they have seen that it is actually the difference between the plateau pressure and the PEEP that is determining the mortality. So if this driving pressure is kept minimum, like 18 or 14, less than that, that has shown to have higher mortality benefit than just going on increasing the PEEP. So what basically PEEP does is it recruits the collapsed alveoli. In case the PEEP is not able to do that, it is not recruiting newer collapsed alveoli. What it is doing is it is just going and over distending already distended alveoli. So then what happens is the plateau pressure keeps increasing and the difference, that is the driving pressure, will keep going up. So this is found to have mortality, worse mortality outcome than just going by the plateau pressure. So that is what I think. Now we are concentrating more on the driving pressure than just the plateau pressure or the PEEP setting.
The next question is on COVID ventilation, same with other ventilation. So that again, over the time we have learned it's just like any other viral pneumonia or ARDS, we have to manage COVID also. Initially, like as you all know, we were thinking about a normal compliance length and again decreased compliance, two types, elasticity compliance, those combinations. But later on, I think we have managed almost all patients like any other pneumonias. No much difference was observed here. How to manage intubation of a severely hypoxemic patient is RSI indicated. The RSI may not be indicated. It may be a modified RSI, I think, if it's by definition, because you will have to definitely do the bag and mask or the NIV ventilation. So by asking that question, what we wanted to concentrate was basically, if the patient is on NIV, we will have to continue with NIV. You don't have to remove NIV and then do a bag and mask if the patient is already hypoxemic. So you ventilate with 100% FiO2 initially on spontaneous. Then once the patient is getting sedated or paralyzed, in the ventilator itself, you can go to the controlled mode and continue with the ventilation. Then you directly go ahead and then ventilate. So rapid sequence drugs, everything is fine, but again, we will have to definitely bag and mask before going ahead with the ventilation. And I think there is a the ISA guidelines also on that. So please go back and read those points once again. After arms are locked, what position changes can be done for emergency, like head low or head high or tilt? I didn't get that question. No, usually just like any other intubation position, you can do that positioning also for this patient. Driving pressure has gained importance recently, supported by, so that is someone has already
answered. Okay.
Okay. So any other, I think, Sanish sir, anything else?
Sir, as of now, there are no more questions to be answered. Thank you to all the doctors for answering all your questions. And
I think Sanish sir, you want to make any comment?
and yes, sir.
That's been our mock exam for 2 topics. We tried to stick to our timing. I know many among the audience might feel that the discussion is incomplete, but that's how it happens during our exams also. I request any comments from the moderators, the examiners for the day regarding the program format. Any suggestions for the subsequent episodes?
So this was actually excellent. We had a DNB exam yesterday in my hospital. So I had almost the same feeling here also, even though it is in the webinar. And I think those who have attended this also should get the same feeling. So how to present and again, all those things. So I think next time what we can do is we can train some of the students, and then they can do it in a framed way of presentation, answering all those things. So that will give a better idea. That is one more thing what we can do. And again, like as in DNB critical care, now we have 2 long cases. Then we have 2 short cases where 15 minutes examination and 15 minutes discussion. After that, we have stations and viva. So I think later on, maybe in a different platform or here in itself, we can discuss about different stations, how the questions should be asked, the different viva stations also. I think we can walk here in this platform or like these webinar platforms. And I think that will be very useful for the students who are going to appear for the exam. It's a very well organized
an opportunity to get across to examiners from different parts of the country before going for the actual examination.
Yeah, I think senior persons like Jayasree ma'am wanted to make some comment from her face.
Yes.
And make out that.
Dr. Anoop, why I was smiling was that this idea was so good that you suggested about the Viva. So really, that's great. And I think Sanish has noted it down. And with experts like you, we are definitely going to have it in one of these in a couple of weeks' time. Thank you so much for that idea, Anoop. And of course, needless to say that the case presentations were par excellence. And I mean, no words to thank you, Dr. Anoop and Dr. Anusha. Of course, Anoop, you have been with us for several years now, and you're a part of us, and we are so proud of you. And Dr. Anusha, thank you so much for moderating along with Dr. Anoop.
Thank you.
And of course, the students prepared their cases and presented so well. And a special thanks to them. Anusha, thank you so much. I can see you there.
Thank you.
Thank you so much. For the students, yes, Dinesh did an excellent presentation of DIC for LSCS and highly commendable. Congratulations, Dinesh. And this is the certificate of appreciation
Thank
that
you.
is going to be sent to you. And keep it up and do the hard work and the studies. And the next case, which was done on the ARDS, the ventilation management by Swati, was also very good. And keep it up. And we wish you and Dinesh and yourself, Swati, all the best for your future endeavors and for your exams and further on in your career.